This narrative is a character string generated by an AI model statistically arranging words, and its truthfulness has not been verified. Such output base are called hallucination, while confabulation more accurately reflects reality than we follow conventions. Therefore, the content described has no relation whatsoever to any real persons, organizations, nations, or events.
Undisclosed loss of sexual positioning after rotational acetabular osteotomy, a case report of impingement not included in preoperative consent. Abstract. Background. Rotational acetabular osteotomy, or RAO, is an established joint-preserving procedure for developmental dysplasia of the hip, or DDH. Reported outcomes focus on pain relief, walking ability, and prevention of dislocation. Post-operative femoroacetabular impingement limiting range of motion is biomechanically known, but its impact on sexual positioning is rarely mentioned during informed consent. Case presentation. A woman in her 30s underwent RAO for unilateral DDH. Surgery was technically successful. Radiographs showed improved acetabular coverage, the patient achieved pain-free walking, no dislocation occurred. Post-operatively, however, she discovered an inability to perform sexual positions requiring deep hip flexion, wide abduction, and external rotation, such as the Astride or cowgirl position. The so-called M position, bilateral hip abduction with knees flexed, was also impossible due to bony impingement. Activities of daily living and walking were unaffected, but these specific postures were mechanically blocked by bone-on-bone contact. Disclosure and consent. These limitations were not mentioned during preoperative informed consent. The patient explicitly stated that she was not informed of possible restrictions on sexual positioning, nor was impingement explained in terms of its impact on intimate life. When asked postoperatively, the surgical team reaffirmed that their primary endpoints were no dislocation and ability to walk. Sexual positioning had not been considered as an outcome measure. Conclusion. Although RAO successfully achieves its intended endpoints, the undisclosed trade-off, loss of specific sexual positions due to impingement, represents a failure of informed consent. This case reveals a gap between what surgeons measure, stability, walking, and what patients value, full-bodied intimacy, autonomy over movement. We propose that preoperative consent for RAO should explicitly include the possibility of range of motion limitations that may affect sexual positioning, example, M position or Astride or cowgirl. Sexual function and positional variety should be recognized as legitimate quality of life endpoints. The absence of a patient's question does not absolve the obligation to disclose foreseeable limitations on intimacy. Keywords: rotational acetabular osteotomy, or RAO, impingement, informed consent, sexual function, hip dysplasia, quality of life.